As I impart information to you today, I would like to ask for your help in proceeding to the next step, and you'll see what I'm talking about in a minute. This presentation is based on a research project that is being conducted at Duke-NUS, and what we've tried to do is look at loneliness in Singapore from both a quantitative and a qualitative perspective. The reason why we did this piece of research was not just for research's sake, but because we wanted to identify interventions to address loneliness, and this is where I'd like to have some of your input, perhaps in the Q&A. So I'll give you an introduction. I'll make it brief in terms of what loneliness is about, because you've heard about it already. But then I'll talk about this project that's funded by MOH and the US National Academy of Medicine, and it's called the Healthy Catalyst Award, the methods we use, the findings, and then we can have some discussion. So as you know, loneliness is defined in various ways, and in this particular paper we said it's a distressing feeling that accompanies a perceived discrepancy between one's desired and actual social relationships. But very clearly, from an academic point of view, loneliness is not the same thing as social isolation. So when you want to measure it, when you want to get funding for programs to address it, you need to have this, understanding and be able to show grantors and policymakers that it's not the same thing as living alone. As the Attorney General said, he was lonely even though he was working with a lot of people. Loneliness is also not the same thing as depression. We often think the two are the same. Depression has been much more studied than loneliness, and we know that serotonin uptake is involved, and SSRIs are something that are actually useful in the context of depression, but not necessarily for loneliness. And we know that loneliness is a health risk, and that I think clinicians in Singapore today are realizing, or policymakers at MOH are realizing, that about 3/4 of readmissions are due to social causes, and a large part of them involve loneliness, which decreases, and we have a paper on this if you're interested, one's probability of visiting a physician for a chronic disease that then becomes acute, and you end up being readmitted into an emergency ward. So in 2015, my colleagues and I wrote a paper for Singapore, and we showed that over and above health risks, as Jacqueline was saying, loneliness increased your probability of dying by 30%. We also completed a paper last year that looked at health span. And as in other countries, in Singapore, if you're lonely, you live 5 fewer years. Controlling for the number of chronic diseases you have, whether or not you're disabled, controlling for your socioeconomic status, your gender, your ethnicity, your education, you will live 5 years less if you are lonely in Singapore, and you will live 4 years more in poor health, i.e. with a disability. So what happened recently? Well, in 2019, I had the privilege of going to Washington, D.C. and the National Academy of Medicine in the United States, and we were put forward a task. We had to be in a competition to win what was called a Healthy Catalyst Award, and Singapore won one of them. Now, it was a global grand challenge to address pressing issues in medicine today. And the award has 3 phases. We achieved the catalyst phase. The second phase is the accelerator phase, which is where I want your ideas. And the third phase is the grand prize, which if we're good at our innovation, we will get up to $5 million to expand it nationally. So, oops, I'm going the wrong way. Okay, so we wrote a proposal to look at, we only had $50,000, so we wanted to look at loneliness in Singapore, understand what it means to older Singaporeans. And we said, okay, we only have $50,000, how are we going to find people? And we said, all right, we have these large-scale surveys of Singaporeans, sort of nationally representative, and we can actually we take the question that we asked in the survey of 5,000 people, which was based on the UCLA loneliness scale, a 3-item question, and identify people who were not lonely, people who were moderately lonely, and people who were mostly lonely. And I'm going to show you what percentage of Singaporeans fall into that category. And using that data, we would then select people for our qualitative study based on gender, ethnicity, education, and living arrangements. So we had to choose our population to interview. We wanted them to tell us what they thought loneliness was. Because remember, a lot of this work on loneliness has been done in the Western context. So all these scales were developed. Well, the biggest scale that Capaccio, that this Attorney General mentioned, was developed at UCLA, and it may not mean anything for our Asian population. So we wanted to see what loneliness meant for them. We wanted to build narratives around loneliness. When did loneliness start in your life? Was it when you were 18? Was it when you stopped working? Was it when you lost a spouse? So it's a life course approach, as Jacqueline mentioned. We wanted to understand the reasons behind loneliness to look at interventions. And then we wanted to look at what were the triggers in one's daily environment. So we actually had them take photographs of when we gave them about 20 cameras, Canon donated cameras, and we gave those to them, and they went around taking pictures of things that made them feel lonely, and I'll show you some of those. So going back to how do we choose people? So we did this cluster analysis where we clustered people into different groups, not people who were not lonely based on demographic characteristics, people who were lonely, moderately, and very lonely. And then we had them do life history calendars, which is where we said, when did you become lonely? Was it transient? Has it been chronic? And then we did this photograph exercise. Now the data, data that we used, right now I'm going to talk to you about 2 data sets because I want you to see how the percentage of lonely older adults in Singapore has changed between 2015 and, actually between the late 90s and 2015. So this first data set has 3 waves of data of about 5,000 people. And the second data set started in 2016, about 8 years later, and I wanted to show you how generationally loneliness has actually declined in Singapore, but remains a significant issue for a large proportion of our older population. When I talk about older here, I'm talking about 60 and over. So this is the UCLA 3-item loneliness scale that I mentioned. First question, how often do you feel you lack companionship? How often do you feel left out? And how often do you feel isolated from others? Well-established scale used all over the world. The questionnaire answers were on a Likert scale, so you could say never feel lonely, rarely, occasionally, fairly often, and always. And higher values meant you were more lonely. So I'll kind of skip through this a little quickly. Here's where I want to show you how things have changed over time. In 2009, in our sample of 5,000 people above the age of 60, half of them were not lonely, but more than half were either sometimes or mostly lonely in Singapore. And this was very, very startling because you compare it to the percentages they were talking about in the US, 20%, 25%. Our older people here are reporting extremely high levels of loneliness. Now, over time, you'll see that the proportion that's not lonely has increased somewhat, but we're still seeing a significant proportion, about 40% who are lonely in Singapore, and that's not a small proportion of older people. So there is a problem. And I wanted to show you in this slide, just focus on the table. I wanted to show you that when we were looking at this issue, we were also interested in how loneliness interacts with personal mastery, depressive symptoms, and social networks. Again, this is slightly more academic. The reason behind this is because, you could say loneliness is depression. Well, it's not. If you can look at these different categories, you'll see that there are people who have low levels of loneliness and moderate levels of depressive symptoms, for example. It's not a complete overlap. You can have high levels of loneliness, low levels of personal mastery, and moderate social networks. It turns out that when you do this analysis and people cluster into these 5 groups, we were able to pick from these 5 groups for analysis purposes, and we actually collapsed the 1s and 2s and the 3s and 4s, so we had low, medium, and high for our work. The low people had high or moderate personal mastery. Personal mastery meaning how much control do you have over your life. And this relates back to what Jacqueline was saying about resilience. Some people don't bounce back very well when they're hit with a major life event. People with loneliness, low loneliness, tend to have either low or sometimes moderate depressive symptoms. People with low levels of loneliness tend to have varying types of social networks. They can be weak or they can be strong. So all this to say is that loneliness is tapping something that these other concepts are not. What is it? So I wanted to show you here, I know there's lots of numbers, but just focus on the red ones. Again, these are these 5 classes of Singaporeans. And if you focus on group 5, which are the very lonely, so they're high on loneliness, they're low on personal mastery, they're high on depression, and they've got moderate social networks. Who are they? They tend to be people around the age of 76. They tend to be women. They tend to be non-Chinese. They tend to have high levels of perceived income inadequacy. They tend to be in poor health. They tend to be disabled, and they tend to have 3 or more physical ailments. So great, this is all quantitative stuff. Doesn't tell you very much in terms of what we're doing in terms of understanding loneliness. So this is a description of our interview guide, and I'm not sure if you can really read it, but I'm not sure if I can really read it. Let's see. Okay, so we have, we asked the participant about their background and then what is the meaning of loneliness for them. We ask about their kinship roles and dynamics, their non-kin networks. We ask about work, daily routines, social perception, and identity and personhood. So we've got all this data basically in our data set, and I'm going to show you today some of our results. So this is just a little bit more detail. The slides will be available to you, so if you're interested in or have questions on some of the detail, I'll be happy to answer your questions after the talk today. But basically, trying to co-create a mind map for the construct of loneliness. So we had people work with pens and paper, we had them work in groups, we had them work one-on-one, whatever they were comfortable with, and we tried to get them to identify what the three concepts meant for them in the three questions. And luckily, they identified with the three questions and were able to understand the meaning of exclusion, lacking companionship, and isolation that were being asked in the UCLA loneliness 3-item scale. We asked them about understanding, as I mentioned before. We asked them currently, what type of situations make you feel lonely, and across which domains. Do you feel lonely in your family, or do you feel lonely with non-family members? Do you feel lonely at work, or do you feel lonely in the neighborhood? And then in the past, what were some of the kind of situations that made you feel lonely? And what would be ideal for you in terms of having companionship? What would be some of the ideal situations? So we talked with 44 older adults. This is a relatively big sample for qualitative work. These are some of the insights that we got. So just to recap, older persons' perceptions of loneliness were in line with what the UCLA scale was trying to tap. So in terms of companionship, they talked about, being able to exchange ideas, having someone to rely on if things got difficult. In terms of feeling left out, they talked about not being able to engage in activities because of health reasons or because they felt excluded from participation. And then in terms of social isolation, they talked about physically being alone and not being understood by people. So what were some of the contributors to loneliness for older adults? The lack of companionship was a major contributor, and being unable to feel better about the future. So not being able to feel hope. So there was a lot of hopelessness that was brought up in the interviews. There was also this idea of not wanting to be a burden to others, to tell their children that they were lonely, or to even tell their friends that they were lonely, because they assumed that would be making themselves look like a burden or like a loser, which is very similar to what the Americans are saying. Not being able to engage in social affairs was another issue that people talked about. And finally, and it becomes a very major one for Singaporeans because we're so focused on productivity, which is again something that Jacqueline mentioned. Losing a role is associated with loneliness, and not just a work role. There was an older woman who said once her daughter-in-law took over her kitchen, she started feeling very, very lonely because she had no longer anything to contribute, and she felt isolated and sort of withdrew from her own family in this particular case. So again, these are a lot of more details. I wanted to note that COVID was of course a time when we saw loneliness, raise its ugly head in the social media. It was always there, but it was made more vivid. There is a digital divide. In Singapore, only 12% of our older people use digital technology, and deteriorating health is another issue that contributes to loneliness of older adults. I talked about being a burden, and I talked about, a lot of us have talked about negative spiraling thoughts because of lack of resilience. So one of the things that Jacqueline brought up is you can be lonely in during different parts of your life, and what the literature shows is people are loneliest between the ages of 18 to 24 and above the age of 80. And I thought that might be interesting to this group because dementia occurs typically shows itself, at older ages, and the 80 plus is the fastest growing age group in Singapore, and they're also the most likely to be lonely. So we do need to intervene for that population. The other significant difference is gender. Gender is a significant difference, makes a significant difference in how loneliness is perceived. And for men, grandparenting is a role that they enjoy and provides them with sustenance. Engaging in work is extremely important for them to feel respected and have a sense of meaning. Mentoring is another thing that they enjoy, and we've actually done some work on generativity, if any of you are interested in that aspect. I'm having a problem reading the slides on the computer because it's so small, so I apologize for turning. The glasses are also not working. Men are a tough nut to crack, and I think in the Straits Times there was something on it the other day. They tend to find it very difficult to make new friends, and they tend to just go it alone. So they go out and they do the activities by themselves. Our senior activity centers, active aging centers that are now being built are kind of missing the mark for the men. So we need to think about that. And men like physical exercise. They're pretty competitive, and they like identifying with close friends. And they mentioned that being able to let go was one thing that would really help them with loneliness, overcoming loneliness. And the importance of religion, that came up as something very significant for older men. Now, older women, slightly different. For them, continuing to provide care in the family was very important for them in order not to feel alone, and also maintaining social relationships. What happens when a woman retires? Our data shows that she goes out and she makes new connections with family that don't necessarily live with her. She starts seeing, sisters, aunts, uncles, cousins, the whole, extended family much more, whereas men do not do that to as great an extent. Women also find ways to help within the house, and that helps them cope with loneliness. Work, again, is a very important contributor to alleviating loneliness. And part of me was thinking, why does it always have to be work? Because Singapore always wants us to work. But it does seem like work is coming up as something that people think and want to do and think will help them, or some people think will help them not be lonely. Women want to invest in relationships and building new relationships. They are interested in doing things to keep themselves occupied, they're more receptive to participating with others, okay? So they actually say they were more willing to do that. And again, they're try to be proactive and also open-minded. They think open-mindedness is an important element to not being lonely, and that's actually true because if you look at depression, and the personality traits, neuroticism and not being open-minded are highly linked with depression, although depression is not the same thing as loneliness. And again, religion comes up as a very important component that protects against loneliness. So these are my conclusions at the moment. Men perceive loneliness to be attributed to factors beyond their control. This is a very general conclusion. Whereas women describe their loneliness as a consequence of their own actions and choices. Now take that as you may. We have to think about interventions for men and women, so this is kind of the mindset that we're dealing with here. So men said lack of opportunities for social engagement in Singapore. And they're not really able to reach out to cope with loneliness. Women lamented decisions not making enough friends, or having children in some cases. But women were more equipped to reach out to their social networks. So that's the major conclusion we've drawn so far. And we think that interventions need to focus on a gender. They need to come with a gender perspective. For men, accepting one's role at home may be a way to intervene. Maintaining work and school friendships. Doing activities alone may be something that they enjoy, and maybe we shouldn't be pushing group activities. For both genders, investing in long-term friendships is important, work and a positive outlook. And finally, for older women, keeping busy at home, being open to making new friends and doing activities with others. One thing that comes out from these findings that makes me take pause, I'm in my 50s, is that being lonely at older ages is really an outcome of how you've lived your life. And I think, going back to this idea of resilience, if you live your life just focusing on work, like a lot of pioneer generation men did, you end up having very few people in your life, apart from your NS buddies, as you grow old. All right, and so there's, we really need to educate people to maintain social relationships over the life course. Easier said than done, but something that we should be more open to in schools and in the workplace. And that is the way that we can build resilience, I think, and prevent loneliness in old age. Now, I'm looking at my timekeeper. How am I doing? I'm doing okay? Okay. Sorry, I took out the photos because I was worried that I wouldn't have enough time. But I'll tell you about a couple that sort of stuck in my mind. One was a picture of a staircase going down and nobody on it. The other was of an empty a tractor just sitting at the side of the road. We have so much construction, nobody in it. And there was a picture of a couple in a coffee shop. And the person who took it said that made them feel lonely because they didn't have anyone to have coffee with. So we have a whole bunch of pictures, and we can distribute those as well. But really, the next step is what do you do with these results? I mean, if Singapore is going to invest in interventions for loneliness, if loneliness really cuts our life expectancy by 5 years, and we know it does, and our health span by 4, what interventions are we going to develop? They need to be gender sensitive. They need to be sensitive by ethnicity. There's a whole bunch of data we haven't discussed yet. And we really need to show that loneliness is not just something that happens to people who don't have a lot of money, but it happens equally across the board. So I urge all of you who've listened patiently to this presentation and seen data being thrown at you to think about ways that we might address this issue. And I'm happy to take questions, I guess, since I still have time. Okay. 10 minutes. Wow, I'm good. Okay. It's the end of the conference. Feel free. Yeah.
Put your hand up or come and stand up to the mics and please ask some questions. Yes, please.
Hi, good afternoon. I'm Kok Yang. I'm a surgeon from Qualitative Hospital. Two questions. The first thing is that spirituality and religion seems to play a big part in reducing the feeling of loneliness. And the issue that we have in healthcare is that we try to make it as secular as possible. Even in the hospital systems, the spiritual part is very difficult to come by. So how do we integrate spirituality into this intervention for loneliness? That's the first question. Second question was with regards to your last slide about having the elderly have more meaningful connections with people. Right, so openness to make new friends, doing activities. I think many of us who have elderly people at home, we struggle with this because sometimes the elderly, they don't want to go out of the home. They prefer to stay at home and rely on the family members for that comfort, right? But the family members is not able to provide that, and they are not open to going to daycare and all that. We end up forcing them sometimes, to go. And yesterday we learned that actually this becomes an issue in regards to, the autonomy of the elderly as well. So how do we balance that?
Thank you for those questions. Is there going to be feedback? Okay. So your first question on spirituality, I think it's very hard when you only have 8 minutes or so, or 4 minutes with a patient, to go into spirituality. But figuring out whether the patient lives alone is one important thing, and then asking about whether the patient has social support. And it's kind of hard to ask about religion, but sort of to get an idea about whether the person has a social support, whether it's religion or family members that he or she can rely on. I find it very distressing in looking at notes, doctors, clinical notes, that everything's focused on the physical and very little on the social. So there are now efforts at Quat Hospital actually to have a sort of a background social demographic information on the patient in front of the doctor, including religion and living arrangements and number of children, so that they can better contextualize where this older person is coming from. So these efforts are underway. To your question on how do we motivate older people to go out and do things, I heard a very interesting story from an American lady who was starting a social initiative on the ground, and she said it was a gym. And what she told the older participants is, you don't have to talk to anybody when you come here. You don't have to make friends. There's no expectation. Don't talk to anyone. So the people said, okay, then I'll go. So the people who were the most reserved and didn't want to go went because they didn't feel pressure, and ended up making friends and being the most chatty. All right, so I think it's the expectation that they have to go out, which I think is something that in Singapore we need to relook, because a lot of older people don't want to do it because they feel like they're being forced to go sit there, talk to the person next to you, make new friends, come back, tell your children, oh my God, I made 2 new friends today. If there's no expectation that they have to do that, then maybe that will ease things up a little bit. But we're quite a long way from that. We need sort of a rethink. If there's some social groups here on the ground who maybe have some ideas of a safe space where older people can go and not be expected to do stuff. And that's where I think we are sort of missing the mark also, because there are older people who don't want to go out and meet new people. I myself am quite introverted. The fact that I'm on here on stage talking to you is 25 years of practice and a lot of deep breathing exercises. But if you leave me to my own devices, I would rather be at home because I'm very happy at home. But I would like to have some social interaction. And maybe if I could use technology to do it, or some way of doing it where I don't necessarily have to go out and be around a lot of people all the time and all that noise. And if I'm older, I probably can't, it's a lot of buzzing. That would work fine for me. But right now, if I have to go to a SAC, it's a nightmare. I would die, okay? All the gossip and all the stuff that goes on. So I need a safe space. So I think we need to develop those places in Singapore so that you can talk about mental health issues, you can go there if you're lonely, not feel ashamed, just be. That's my 2 cents. Okay. Hi, Giles.
Hi, Angelique. Good to see you again. Thanks for your fantastic presentation. I think you achieved a lot with that Catalyst Award. I had a quick comment and also a question. I'm a psychiatrist, as you know, and you made an important point to state that loneliness is not depression. But as a psychiatrist, in 10 minutes, I can treat depression, I can't treat loneliness. I can reach for the antidepressant, which helps the serotonin. I don't know which chemical is involved in loneliness, so I can't do anything about that. So I wish I could prescribe social connections, because that will help, but I can't. So that's a comment. And then my question really is, to what degree do you feel we have medicalized loneliness, made it a medical problem, such that it is now actually managed, not quite in the way that perhaps is addressing the issues and maybe your research is finding? Thank you.
Sure. I think right now we've medicalized loneliness as depression. I think a lot of clinicians may conflate the two. But as I've tried to describe today, they're actually very distinct concepts. So, as a person who's gone through depression myself, I can be not lonely, but have all the symptoms of depression that is only fixed by an SSRI. So loneliness is something different. And it's challenging all of us to think about what that is. And I think it is social connections that one has maintained over their lives. We did research that showed that it's not the quantity of friends you have, it's the quality. So I have 3 good friends, and that's enough, support. So you can't prescribe social connection, but perhaps talking with the family, you can maybe get them in a situation where they are more likely to make social connections. It's a hard one, Giles. We'll have to sit down and kind of talk through how one would do that. Yeah, it's not easy, otherwise people would have started doing it a long time ago. It's only now that this issue, there's a minister for loneliness I wanted to mention in Japan, and a minister for loneliness in the UK. Can you imagine? It's only now that we're starting to see it as a major issue, and then hopefully the research grows, and then we have more interventions. There was one other question?
Hi, I'm Kui Hin. I'm the private surgeon.
Okay.
Sorry. First, I must congratulate you on this qualitative and quantitative studies. Indeed, you have injected very deep reflexivity in your analysis, and I'm impressed. My question is, I realize that, especially for the baby boomer, we invested a lot of time in our work. The moment when we stop working, we lose our identity. How do you find the relationship between identity and loneliness? Did you discover these are closely related, or they are just casually related?
Thanks. They're very closely related. So for men, identity is caught up with work. Luckily for women, it's usually more evenly distributed between being an employee, being a mother, being a grandmother, being a sister or a daughter. But that's why men are particularly hard nuts to crack, because once they stop working, I mentioned the NS buddies, they have them, and they have some friends from work, but their identity is so wound up in work, they haven't spent a lot of time investing in emotional ties with their children. In fact, they've urged their children, in most cases, to study, right? So they haven't seen them, and they may or may not have invested time in building links with their spouses. But identity is very much caught up in this whole notion of loneliness. Who you are, meaning in my life, do I contribute? think we have one.
Sorry, thank you so much for this really interesting talk. I'm just thinking, by the time you come to the older men and older women, you've missed the boat, right? All
Right.
the things that have been done are kind of set in their way. So what do you think we should do? I'm a pediatrician. So what do you think we should do upstream to prevent coming to this? We're kind of like plugging our finger into the dike when it's already it's too late, right?
Yeah, you're right. You're right. It's not too late. I mean, I still have hope. Yeah, we can. There's still things that can be done. But I think that, and I'm probably like an old record, but you know, the education system in Singapore is very focused on results, and we have not, well, prior to COVID, been very open to discussions around mental health. I'm speaking to the converted here. But the idea that you live a more balanced life and really invest in what sociologists like to call is a social convoy. So a convoy of people that are with you throughout your life. And it's something you have to work at to maintain those relationships, because people move and people get busy. But having a social convoy is extremely important to successful aging. So upstream, you know, start as soon as we can, encourage, you know, young adults to invest time in relationships that will benefit them later on. Maybe hard to get them to realize that when they're trying to work up the corporate ladder, but I think the younger generations do understand issues around mental health better than our generations did. So we just need to keep plugging away at the message that social connectedness is extremely important.